Join us for an open house at Monument Health Family Medicine Residency Clinic April 4th from 1 to 3 p.m. Meet our resident physicians and nurses, enjoy complimentary health screenings, take a guided tour of the clinic, and grab some light snacks and beverages. This event is designed for community members age 65 and older. Don't miss out April 4th, 1 to 3 p.m. at the Monument Health Family Medicine Residency Clinic, 502 East Monroe Street, Rapid City. See you there. Welcome to Doc Talk, a weekly podcast featuring Monument Health physicians addressing medical topics. Tune into your health with Monument Health. Hello again, everyone, and welcome to another edition of Doc Talk with Monument Health. My name is Mark Houston, and joining me today is Dr. Jennifer Callahan, who is a doctor at Monument Health and a doctor of a DO, osteopathic doctor. Did I get that right? Did I say it right? Perfect. That's Bobbie Schneller, who is here with us as well. You're also the program director of the Monument Health Rapid City Hospital Family Medicine Residency Program,
yes,
which we're going to talk about here for most of this podcast. But first, since you guys have never done this before, I want to know where you're from. I need family secrets. Okay. Let's go back and figure out how you got here. All right.
You know, all right.
We'll start with you, Bobbie, for sure.
I was born in Minneapolis in the Twin Cities.
Oh, great place to live.
It's a great spot. It's really, the wintertime's not as much
fun,
but you know. I'm the oldest of 5 kids.
Okay.
And I believe I told my pediatrician when I was 3 years old that I was going to be a doctor, kind of similar to your little one.
That's hilarious
yes.
that you guys, so many times I talk to the doctors we've done in this podcast, and you've known from such an early age.
It's almost like a calling. I believe in callings.
Oh,
and
maybe.
I heard it pretty early. I knew this is what I was going to do. I deviated a couple times as a teenager, but really never too far off this.
Did you have family that was?
None.
None at all?
No, I'm actually the second woman in my family to go to college and the first person to get a doctorate in my family.
Wow.
3 of my siblings have masters or doctorates after me, but I'm the first person in all of the
So you show up at the family events and you're like,
That's
that
me.
was first. The rest of you guys, whatever, tag-alongs. So how about you, Jennifer? How did this all begin for you?
Yeah, so I was born and raised in Omaha.
Okay.
And that's where I met my husband. And I knew pretty early that I wanted to be a physician as well. My pediatrician is definitely the one who helped me make that decision.
Really?
Yeah. Mm-hmm.
So did you have, in your family, was there any doctors or nurses or nothing at all as well?
No. My mom was in mental health. She was the first to go to college. I was the first to get the doctorate as well.
Well, if your mom was in mental health, I suppose that kind of
similar.
I mean, there was a path there. Obviously, as doctors, you guys, what I'm finding out more and more in talking with you is that is playing a bigger and bigger role in what you guys do, for sure. Absolutely. You know, it used to be, I think people would come in, doctor would say, "Here's what's wrong with you. Here's the medication. Go home, get better." But now, do you guys find yourself spending more time with the patients?
Absolutely.
While you're getting to know them a little bit, which is kind of, I think, what we're going to talk about a little bit here too. Has that changed since you guys started in this field?
The time that you spend with the patients?
Right. I mean, getting to know them as much. Have you seen that change?
It's the most important thing about family medicine. So one of the tenets, the foundational aspects of family medicine is that we have continuity with our patients. We get to know them. I've had families where I have delivered the babies, I've taken care of mom and the siblings, I have taken care of the grandparents, and I have had the great-grandparents in hospice, and that is just an amazing experience and really one that you only find in family medicine. So,
okay.
Mm-hmm. And you get to know those families, you know all about them, and they come in and, how was that trip to Alaska? Did you get any fish? And you have those conversations, and you're part of their family, which is what this job is all about for me.
Absolutely the same. I mean, that is the reason why I didn't go to pediatrics, because I wanted to, hey, can you see my mom? And, my dad's knee's bothering me, and my grandma needs help with her diabetes. Can you take care of that? Yes.
Well, let's dive into that then. This is the family medicine residency program that we're kind of focusing on with this podcast. And as we were talking before we started, I think a lot of people go to their doctor but don't realize that doctor isn't there from the time you're born till the time you die, right? And that's what you guys do, and that's the difference. Can you explain that a little bit more?
Absolutely. So, if someone's pregnant, we take care of them during their pregnancy, help make sure that baby's healthy and safe. Then we get to deliver them. We get to take care of them in the hospital for their newborn exams, follow them in clinic as they get bigger, and basically everything they need from that point on. And I think one of the greatest joys of my job is helping people live their lives the way they want to when it comes to time being short at the end. I think that's really important. So we do it all.
It seems like what you guys do then, does it require more schooling for you guys to do this for kids to 99-year-old? Or is I'm just amazed that you guys cover that whole thing and not as a specialty.
It's a different training than some of the other specialties.
Okay.
So the specialists get to know a lot about the organ system that they're working on. Cardiologists, they know more about hearts than anybody. We have to know a lot about a lot of different systems. And so we can identify what is the problem and do they need to go to a higher level of care to a specialist to manage that problem, or can we do it in our clinic? And many times we can manage it without having to send them on to the specialty care. But it's also recognizing when they need that and being able to send them.
How many types of doctors like at Monument like you guys are there?
I believe last time I looked, I think there's 33 specialties at Monument Health.
Is that a lot?
It's
for
this
a hospital
town,
like this? Yeah.
Yes, absolutely.
Okay.
I think we'll be looking toward having more pediatric specialties in town in the near future. Just that's a goal for our community. But for the size town we are and the facility we have, that's amazing to have that.
Well, and it's growing too. I mean, Monument is exploding right now, which is fantastic for the size. For this size market.
It's great news for the community.
Yeah, we don't have to go to Rochester or Minneapolis or Denver for almost anything right now. I mean, there are obviously some things that would pop up that you might have to. But what's awesome about what Monument's doing here now is we've got the people. So if you've got something wrong, you get to stay here.
Well, and in a world where our critical access hospitals in the country, rural hospitals are shutting down, we're expanding ours. We're putting our graduates are in most of the hospitals in the community outlying facilities. So Spearfish, Sturgis,
of course,
Lee, Deadwood, and Custer. We have graduates in all of those facilities, and they're making them better, and they're getting great care out in our rural communities as well. Do you find
that some of these people that are coming into the medical field now, do they want to work more into specialties, or is this family medicine what you guys do more appealing? I mean, what was appealing for you guys for it?
I had not decided what I wanted to do. I was probably at the very end of my third year, beginning of my fourth year of medical school. Medical school is 4 years. And I was kind of thinking maybe I wanted to do gastroenterology. I was flirting with it a little bit, and I came and did a rural rotation down in Custer. It was basically a way for me to spend a month with my family, because they lived down in Custer at the time, and get a feel for that hospital system down there. And I loved what they did. They were still delivering babies at the time. They don't do that anymore. But they did ER care, and they were delivering babies, and they were admitting patients in the hospital. They did an urgent care, and then they had regular clinic days. And I was never bored for a second. Walking into each room, it was something different. It was interesting. Some of the specialties for me, they get a little boring. You see the same thing over and over again, whereas I never know what I'm going to see in any given day. And I loved it, and I never looked back from that rotation. I was with Dr. Joy Falkenberg down in Custer, and it was wonderful.
Sure, yeah, we've had Joy on.
Yep.
Yeah, she's been fantastic. Does that kind of mirror you as well?
Similar. It was the continuum of care, wanting to take care of every age and being able to do as much as I could for people. You know, when you walk in to see your doctor and you have 3 complaints, and you can address all 3 complaints. That's really nice, instead of having to be like, hey, I'm going to send you to these 3 people because I can't do that.
Right.
And so that's really rewarding when you can do something right there in the moment. And then again, seeing all sorts of different types of walks of life and helping people with all sorts of different problems is really meaningful.
So do you think you will see, you probably will in your practice, you are going to see people that have been born, and I mean, as far as you can take it with these people then as well, aren't you?
Some of the babies I delivered when I was in residency, because I went to this residency program for my 3 years, are getting to be of an age where I might be delivering their babies. So that's a little concerning. I think I might be getting old, but it's actually a reasonable possibility at this point.
I hear that they just grow up so quick anyway. Right, that's what it is at this point, right? So really quick too, can you explain the difference? Like I said, you are you're what's known as a DO, and you're an MD. What is the difference between those two?
You want me to take that one?
Sure.
Okay. So basically, they're very similar. We have the same medical training as far as the same textbooks, the same coursework. In addition, DOs have a little bit of training in what's called osteopathic manipulation, which means you might think of it something similar to chiropractic medicine, but it's a little different. And it was founded back in, I know this date, 1892.
Oh wow, it's been a while then.
Yeah, so it's been a while, and it's something extra we have in our toolkit. If someone has low back pain, we can do something besides prescribe medications or send them to physical therapy. We can do things to make them a little more comfortable in the meantime. In our program, it's traditionally been about 50% DO, 50% MD, and really you can't tell the difference between our residents. Yeah, just they may add on a little OMT in their clinic days, but really they're very similar. And actually, in the last few years, our accrediting body for residencies, it's the ACGME, they combined with the DO residencies, and so there's just one match for both DOs and MDs.
Okay.
It used to be different, but it's last few years now it's been the same match.
So then an MD, I'll let you explain what that is in comparison.
Yeah, so I mean, it's essentially the same thing as far as the coursework and the learning, except they are able to do osteopathic manipulation, which they're taught in their medical school.
Well, is osteopathic, is that also, is it, I've read or I vaguely remember coming across something that said that it's looking at, like everything that a person goes through, their nutrition and their mental health and their physical health, and you're trying to fix some of those things that then can help with their physical health. Is that kind of what that is?
So the philosophy they teach us is the body works together.
There we go.
Everything works together. The body's a unit, and that the structure of the body and the function of the body are interrelated, and it's the doctor's job to put the body in as good a condition as they can, the structure, so that it can heal itself. And that's kind of the philosophy we work under. I think MDs have a similar philosophy. I don't think they say it the same way as we do.
Yeah, so essentially they learn additional techniques for physical touch of the patients to help with alignment and those kind of things. But yeah, we still
optimizing their health.
Yeah.
We still learn about the importance of nutrition and all those other things. Yes.
Well, it seems like that. Yeah, that's a very fine line then between the two.
Yes.
For DO and MD
they
for sure. They
wouldn't have thought so 30 or 40 years ago, but it really they've gone
Why
parallel.
do you say that?
There was a lot of animosity, I think, between the two groups back in the early 1900s, and then but really over the last 20 or 30 years, I would say they've just kind of run into alignment, and they're very similar.
Well, just a normal schmo like myself thinking about it, I'm thinking, well, that just makes sense, because why don't you treat everything? If somebody comes in and they don't feel good, and you get a chance to sit down and talk with them at length, chances are you guys are going to realize, well, wait a minute, that's the physical pain, but it's coming from something else, right? I mean, is that...
The founder of osteopathic medicine was actually an MD and had some children who were sick, some of his own children, and just didn't like the options available to him in the 1800s. And so he developed the additional manipulative medicine, the OMT, to be an adjunct to the rest of the medicine he had learned. So it was a parallel track, but people weren't particularly happy with him for leaving the traditional MD stuff. So we had a little family argument in the past, and we seem to have come back together nicely.
There's all that bloodletting that you decided not to do
we got
anymore.
Rid of that. We don't do that at all.
The four humors are...
Neither group does that anymore. So.
All right. Well, I know one of the other things that kind of came up here when I was looking through this, you guys, I think we wanted to talk a little bit about older people that are like 65 and older. Why is it a lot of these people anymore, you see, we're living longer, obviously. And people that hit 65 years old, a lot of times, if they're taking care of themselves, they're like, why do I have to see a doctor? I feel just fine. But why is it important that they need to come and see you guys?
So a big part of family medicine is preventative care, right?
Yep.
So people don't know they have high blood pressure. They don't feel that they have high blood pressure. And so if you don't go to the doctor to have that measured or to be examined, you won't know that it's happening to you. And that can prevent, heart attacks and strokes and all sorts of really important things. And then there's the vaccines, right? So
of
we
course,
want to make sure
yes.
that you are getting the appropriate things so you don't end up with pneumonia or RSV or whatever the terrible thing is that is,
Yeah, right.
Shingles is not fun.
No.
You don't want it. You just
No, it isn't. Oh, boy. I can't recommend that vaccine enough, although that second shot is...
I've heard that one's uncomfortable.
Yeah,
so.
it's a piece of work. Just take the weekend off if you're going to have it and stay in bed.
I'm due for that. I'm going to need to come see you.
Well, and there's other vaccines too. I know that I'm at that age where I have to have those vaccines. Well, they lowered the is it pneumococcal pneumonia? Mm-hmm. Is that the one where it used to be 65, now it's 55?
Yes.
So that's another shot that they highly recommend. Again, you could feel fine, but those type of things are super important as you get older to make sure that you don't die.
And this year we've had just a very I'll call it robust flu season. It has been a rough year for everyone, but we know that people who get the flu shot, it may not prevent them from getting influenza, but it's going to make your symptoms milder, much less likely to end up in the hospital. It is very rare that I hospitalize a patient who's had the flu shot.
Now I saw, I don't know, this is a little off topic, not really, but did they, every year they kind of have to guess which type of flu it's going to be, right? Mm-hmm. Why is that? Why don't they know?
Viruses mutate. They change.
They
change every year, and the flu tends to do it yearly. And it's always a little bit of a surprise what strain is going to be the predominant one. And so, the scientists do their best guess.
Sure.
And usually, it's a pretty effective vaccine in minimizing symptoms.
I
got the shot. I got flu a couple weeks ago. I was fine.
Yeah, I did too. It was almost 2 weeks ago. So exact same thing. And I was like, well, don't feel great,
well,
but it's you got through it. But why don't they just do both? Or why don't they give you all of the vaccine of whatever the flu is?
Well, there's really two types of influenza. There's A and B.
Right.
A is usually the one that makes people the most sick, and we immunize
really?
for that one.
Yeah.
But there's different subtypes, and so there's so many different subtypes that it would be impossible to guess. And it changes from year to year. So
okay. Mm-hmm. So they do your best guess, and even if they don't guess correctly, it still can help you
absolutely
not feel as crappy when it rolls around. All right. Well, what are some of the most common health issues that you see in older patients that may feel fine, but they're coming in and now you're like
hypertension is the big one.
Is it? I suppose that would be.
I will have patients come in and their blood pressure will be off the charts, and I say, okay, we have some high blood pressure issues, and probably the most common thing I hear from patients is, well, I've never had high blood pressure before. So that's probably true, but your vessels aren't meant to last 65, 75 years, and most people will end up with high blood pressure. They don't necessarily feel it. However, it does, as Dr. Callahan talked about, it increases your risk for so many other things. And so that's one of those things that we look for. Sleep apnea is another big one for our patient population. They don't realize why they're so tired, maybe cranky, memory's not going well, and we identify that they are probably high risk for sleep apnea, get them their study, and you see things. Once they're treated, they do much better with their diabetes numbers come down, their blood pressure comes down, their memory gets better. Family often says their mood gets better. So sleeping, it turns out, is one of those necessary things.
When you get some sleep. Speaking of high blood pressure, is it something that is getting easier and easier to treat once we find it in people?
We have so many tools in our toolbox.
Yeah.
There's so many different types of medications, and sometimes, with exercise and diet changes, you don't need a medication.
And that's it.
Yeah.
Oh, well, that helps. I mean, that's good to know. And that's why, like you said, if you
have untreated sleep apnea, you often have high blood pressure. Sometimes treating the sleep apnea improves your blood pressure.
Those two get tied together too, huh?
Oh, absolutely.
Really?
Yeah.
Oh, fantastic.
That's why we went to school for so long, to figure out all these connections.
No kidding. So how long has that family medical residency been here in Rapid City?
So we, in June, will be celebrating our 30th anniversary with the organization.
Way.
Yes.
Wow. So are there new services or improvements that people can expect when they're coming into this?
Always, but we've graduated over 150 doctors into the world in our 30 years, so that is a
big number? I mean, is that a lot for
we have
here?
Six residents a year, roughly, moving up to 8. But it is.
Oh wow!
You think about the doctors usually stay in Western South Dakota or in the states that touch us, in those rural areas. That is an amazing service to the community to be able to have doctors in those communities.
Well, and Jennifer, you made a comment when we were out in the lobby about I was talking about Omaha. It's a pretty cool big city, compared to what we have here in South Dakota, Rapid City. I love living in Rapid City. I've lived here almost my entire life. But I do love going to the cities, right? Yep. Anytime I can go to the Twin Cities, Denver, Omaha, whatever, it's a blast. And you said that you almost prefer working in a smaller community.
Absolutely.
Because of what you get to see.
Yep. I love Omaha. I always imagined I would go back to Omaha.
Right.
But I couldn't practice the medicine I practice here in Omaha because it's such a bigger city and people are so much more likely to go see their specialists. And so, in Omaha, you probably would take your kids to the pediatrician. The pediatrician's going to see them from birth to 18 months. You're going to deliver in a hospital with an OBGYN. Instead, I get to do all of that here, and I don't have to live in a tiny, tiny city, but I still get to see babies all the time, and I still get to deliver babies, and I get to do all sorts of things that probably wouldn't be as big a part of my practice if I was in a bigger city.
Why do people do that, though, in bigger cities? Why don't they have doctors like you that they stick with from birth to...
They may see them for more minor things just because the specialists are available.
It seems like they'd be overwhelmed, the specialists in big cities like that.
Yeah, absolutely. I did some of my med school in a bigger city, and the family medicine there, basically all they did was fill prescriptions and send referrals. And so, they're busy as well. And I think that no matter where you are or whatever specialty you're in, you're going to fill up quickly.
Yeah.
The thing about family medicine is you can really turn your practice into anything you want it to be. If you want to go work in urgent care, if that is the practice you want, you can go do that. If you want to do full spectrum family medicine, you can go to a rural area, work in a residency program, and you can do all of the things. If you want to do just outpatient medicine, there's plenty of opportunity to do that. We have residents who work in ERs. In the rural communities, former residents. We have former residents who work exclusively as hospitalists. Even at Monument Health, we have two of our graduates, I believe, are hospitalists at Monument Health right now. So you can make the practice whatever you want to do, or you can do what we chose to do, which is go into academic medicine. So we do all of the family medicine things. We also train the next generation of doctors, which is a really fun job.
What do you guys do for fun?
Oh my gosh.
Good Lord.
I have 3 kids, and so we do a lot of fishing, boating. We do. My youngest just caught the biggest fish of his life. It was almost bigger than his, so he's pretty excited about that. He'll love the shout out.
Well, is that,
camping, all that stuff.
You see, just do like the stuff that we like to do around here to begin with, for
Absolutely,
sure.
yes. I also have 2 small children, and so they keep me very busy, and we recently built a house, so we're doing a lot of landscaping and gardening and that kind of
you will
stuff.
have a busy summer.
So what we don't do is sleep.
No, I don't know how most of you doctors, you always talk about how important getting sleep is. And I don't know how you guys, I honestly don't know how you do it. It's amazing. So we talked a little bit about, the importance of people being, 65, 55, older, coming in to see you guys, even if they feel all right. How do you guys encourage them to come in before these problems arise?
Just by having follow-up. One of the things when they come in and they establish with us, we will say, all right, you have these issues, and we want you to come back in a year, or we want you to come back in 6 months, or maybe a month from now, to just see how our treatment plan is working for you. And so establishing those relationships over a period of time, which is one of the nice things with family medicine. If you have that established patient relationship, they're going to listen to you, and they're going to come in and say, yep, I need to come back when Dr. Schneller asks me to. And you partner with your patient. It's not me telling them what to do, which is maybe what people think about medicine. When they think about doctors traditionally, I'm telling you what to do. Yep. Really, it should be with your family doctor, a partnership. How does this sound? We need to make a change. Are you willing to make this change, or what questions do you have about that? And it should be a conversation with your patient. So that's what we try and teach our residents to do too.
Yeah. Well, I suppose that, like I said, when we started this, that's going to make such a huge difference. The way it's kind of transitioning from doctors really sitting and listening, getting to know people. And I think that's going to take away some of that fear people have about going to the doctor too, because you still, and I have to assume that around here, we're Midwest, Western South Dakota, we have a mentality of well, we'll take care of ourselves, and we're tough enough to do this, right? I imagine you guys get a lot of people that come in like that that are like, look, I don't know. My wife said I had to come in here, so now I'm talking to you guys. How do you handle those situations then?
Well, it just kind of depends on the individual, right?
Yeah.
But for the most part, if you listen and you hear what they have to say and you ask good questions, you can develop that relationship.
It seems like that's the key. Once you listen to people and I think they kind of feel heard, then they're going to open up a little bit more and allow you guys to help, which...
And they have more visits with us. In family medicine, you're going to see your primary care doctor more frequently, so you're going to have more opportunities, more touch points to get to know that person. It probably doesn't necessarily happen on the first visit.
Right.
They have to trust you, and that takes time to develop that relationship, and we have that in family medicine, which is nice. The other thing we do in our program, and I think we may be the last group in Rapid City to do that, when our patients get admitted to the hospital, we see them there.
Oh,
so
really?
Most of the time.
That's not common?
That's not common anymore. No, when I trained, it was still common, and I graduated in 2009, that the community docs would go in and see their hospitalized patients. Medicine doesn't work as well that way anymore, just because they're so busy in their clinics, and we have a hospice group. They're wonderful. They're a fabulous group to work with. But for us, it's nice to see our patients in the hospital, know what happened with them, with their whatever happened to them in the hospital, what things need to be followed up on. That continuity of care is very important to us.
You've mentioned the word hospitalists a few times. What is that?
Those are doctors who are in the hospital all the time. That is their job. They do so many shifts a month in the hospital seeing hospitalized patients, but they don't necessarily have a relationship with them on the outside of the hospital.
Oh, I
And so
see.
that's medicine is moving that way more and more, I think, nationwide, and it's not a bad change.
Right.
It's a good thing. But for us, we like that continuity of care. I think that's important to both of us. I know it is.
Absolutely, and I think it helps with the patients too. Like, I'm going to go see this doctor that I saw in the hospital in the
Right.
clinic, and that makes them feel like we know them better. And I think it makes them want to come see us more.
Yeah.
Often I'll walk into the ER and it's a patient I've known for 10 or 15 years, and they see me walk in the room and they smile, and I'm like, okay, they're comfortable with me. That's a good.
Like, why were you on that skateboard? You're too old for this.
We have had that conversation before.
So what's one piece of advice you wish these senior I hate that word senior patient, but yeah, okay, we're up there, 55, 60, 65 years old. What do you wish that they would take to heart most when it comes to their health?
That they're important.
Oh, that's a great answer, honestly. Yeah, I don't know how much more you can expound on that, really.
They're often so busy taking care of other people,
Yeah.
and they just kind of ignore their own things, and ignoring your health is one of the worst things you can do for longevity. So.
Well, and we're like we said, we're able to get older. One of the good news pieces I read not too long ago is for the first time, I don't know how long, life expectancy in America has actually grown. It was receding for a while, but I wonder if, especially what you guys are doing, and that communication that I'm just finding out is so important anymore between doctors and patients, if that's not kind of what may have turned this around a little bit. People are trusting a lot more. Hopefully.
The communication piece certainly doesn't
Yeah.
hurt with that. It is, you're more likely to trust someone that you can have a conversation with, and hopefully that's what family medicine provides. We need all of the specialties. This is where our niche is. So.
Does it make your days, when you have to sit down and communicate, and explain and get to know, do you see less patients because of that, because of the time? Not really?
It's the most rewarding part of our day.
Yeah.
Mm-hmm. Yeah.
But you're still able to see like the same amount, even though you get to spend time and.
That's what the training environment is. Initially we start
right.
our residents out, our first year residents. They've graduated medical school. They're doctors, but they need that supervised practice. Their first 3 or 4 months in clinic, they get 1 patient an hour. So they learn to kind of.
Wow.
Yes, it's very slow, but they learn to talk to patients, and they learn to develop some efficiencies. And then we turn the heat up on them gradually throughout that 3 years of residency, so that they're able to see a patient every 15 or 20 minutes by the end of their 3 years in residency.
That's amazing.
And still get that information out and develop those relationships, but it takes some practice to be able to do that in a short period of time. On average, I think family medicine has 11 minutes in the room with a patient, just on average nationwide, and that's a lot of things to take care of in a very short period of time.
My goodness, it is. Because you got to have some people that come in too, I'm assuming, are just talkers.
There are a few.
They want to ask every question. And
There's some of our favorites that we
Oh,
really
I'm
like
sure. So what do you, when it comes to like people that might be looking to get into this type of residency and want to do this kind of thing, do you have advice for them too that you guys have learned that you'd want to tell them?
Oh, there's so many things to say. I mean, there's so many things to say. Ultimately, it's follow your heart. Medicine is wonderful. It's really hard.
Right. Oh,
so
of course.
You have to be willing to put that in. And I think that if you're going to go to family medicine, you should go to a rural setting so you can really get all the experiences that you need to decide what you want your practice to look like when you're done with residency.
Okay. Well, that is good advice. What about you?
You know, many of our doctors have put off having families until they get to this point of their career, and it's very hard to kind of integrate all the parts of your life. Work-life balance isn't really a thing. But there are times in life where your patients are going to have to come before your family.
Yeah.
It's just the job is that sometimes you have to stay late. You have to deliver that baby. Your patient is critical. You're going to stay with them. Make it up to your family in other times. There's plenty of opportunities to do that, but sometimes the job is going to outweigh the family life. Sometimes the family life has to outweigh the work life, and it's finding what's right for you. So
boy, yeah, that balance would be very tricky in the profession that you guys have, for sure.
I think most of our kids have a really good sense of empathy, though, because like my kids, did you go deliver a baby today? Or is your patient okay? They know they can't find out anything about it, but they know I had to leave, and that means that something happened at the hospital. So my kids have a little different perspective of things.
Oh, that's great, though. But I mean, your family, who your family is has to understand what you guys are doing, too.
Absolutely.
They have to know that this is...
Not a 9-to-5er.
No, exactly. Now, before you guys got married, did they know what you guys were doing? I mean, did you meet as you were starting this whole journey?
I met my husband in undergrad.
Okay,
and
all right.
He is the reason I'm successful. I mean,
awesome.
He's done nothing but support me in this process.
Oh, that's great.
Same. I met my husband in undergrad. He's been the most supportive person in my life.
Are they in medicine? Either one of them?
Not at all.
No,
he was a combat medic in the Army, which he says was very helpful for being a stay-at-home dad of 3 boys. So.
Oh my goodness! Yes, that's about the best way you could have put that. That's great. Then, what is your husband? Is he?
My husband owns Casey Trailers, but
really?
He's primarily a stay-at-home father. And
cool.
I would say that being married to someone who's not in medicine is probably one of the best things ever.
Yeah, it seems hard. I mean, if you guys are constantly, if you have the same profession, especially in medicine, God, that would be hard to make things work, because how would you ever see each other unless you worked in the same, I don't know, hospital, department, specialty, whatever.
There's lots of doctor couples that make it work, but for me, I don't know, 2 type A personalities in one family might be a lot.
Well, this has been a lot of fun talking to you guys about this. I've got to learn quite a bit. The difference between obviously DOs and MDs and hospital family medicine and how that works. Not hospital family. I read that as the whole thing should have been Rapid City Hospital Family Medicine. But you guys, it's very interesting the paths you've taken and how much you genuinely enjoy it. And that's what I love to hear more than anything, is when you go to see a doctor, we've talked a little bit about the trust that you put in them, but to genuinely feel that you guys love doing this is such a relief, I think, in those scary situations.
Well, thank you.
Yeah, absolutely.
I can't imagine doing anything else. I've been doing this for a while now.
Oh, this is great. You guys plan on, this is the rest of your life? This is, you don't want to do anything else for sure?
I don't see me going anywhere.
Oh, my God. That's great. Dr. Jennifer Callahan and Dr. Bobbie Schneller, thank you both for coming in and talking with me. I appreciate it. And next time you guys want to talk about, I don't know, you sound like you really like delivering babies, so I would love to talk about that too, and what a day looks like for something like that. That'd be fun. But anytime you guys want to come in and talk about, let's do it, okay?
Sounds great.
Thank you guys.
Thanks. You.